It's an absolute pleasure to be with you guys. मैं चीमा साहब को ये कह रहा था कि हमारी तकरीर जो है is between you guys lunch. So I'm the last one. I'll try my best to be as quick as possible. So I know I'm talking about the updates. So rather than I'll talk about all the jargons of the different cytokines and all the names associated with this. I know I'm talking to non-rheumatologists and I'm sure you guys are all uninterested. So I'm going to discuss about the concepts, the basics. I hope I'll be talking just the two things only. Rather than just the drugs, the cytokines, as I said, I'll be talking the concepts mainly. So the main important concept is the window of opportunity. Of course, we are talking about the management, like what is more important, not just for the patients, but for us as well as the whole concept of window of opportunity. And of course, the whole expectations are also changing as well, if you like. I remember, like, if you talk about 20 years ago, the whole expectation was how to improve the quality of life, how to improve symptoms, how to control symptoms. And the best thing we could think was how to prevent irreversible damage. But naturally, with the whole advent and the discovery of new drugs, the new cytokines inhibitors, and the new targeted therapies, what we are talking about is how to achieve drug-free remission. And that is, of course, is a major challenge. And I'm going to show a little bit dilemma when it comes to it. Why I'm saying dilemma is the most difficult part to practice in Pakistan is what? The most difficult part, what I really struggle to date, every single day मेरी मरीजों से ही झगड़ा होता है. क्या है? How to break the myths. पाकिस्तान में myth ही myth हैं हर बंदे. और डॉक्टरों के patients का क्या है? I remember dozens and dozens. I have hundreds of the juvenile patients. Literally, the patient with the vasculitis on the deathbeds. But the moment the patient improves, what they want is कि उन पूरी उम्र दवाइयाँ खाई जाइए. That's the problem. So that's a major thing, how to actually discuss with them, how to break the whole diagnosis, how to give them the whole treatment plan and all this. And then we'll be discussing about the therapeutic armamentarium. So of course we know the rheumatoid arthritis, of course, is a very common condition and all those things. Unfortunately, the woman folk gets the more hit, 3 times the more, unfortunately, they get affected. Of course, it can happen at any age. I have literally 90 years old patient as well developing the rheumatoid arthritis. This is what we call elderly onset rheumatoid arthritis, seropositive rheumatoid arthritis. So no sort of the age spectrum is spared of this. So most of us understand the whole concept of what we call the whole treatment pyramid. So this was before 1990s. Of course, we start with a whole lot, as you can think of, you know. And this is, I'm talking about in late 90s when I was reading my Davidson in the final years. So these are all like the gold injections and so many other things, the anti-malarials and all those, the steroids and all those things. But now, seriously, this is all, the whole pyramid has gone haywire, okay? So this is what we call the reverse of that treatment pyramid. So now, naturally, we start with very day one, we don't wait. We think the patient has got chronic arthritis. Chronic arthritis, earlier on we used to think the chronic arthritis was that if the inflammation is lasting for more than 6 weeks. But now we talk about is even 2 to 3 weeks, we notice that this is something a little bit more chronic. We should be thinking of making a plan from the day one rather than waiting for another 2 months or 3 months for making the plan. So naturally, we move now much more quicker and much more faster. And we'll discuss that. So if you ask me, why do we do this? Like, what's the rationale behind the whole inverting the treatment pyramid, starting with, like, just the blood pressure we were talking. We start now, if anybody comes with of course, the major signs and symptoms are the true polyarthritis, and of course, the high titers of rheumatoid factor, anti-CCP antibodies. We start literally not with the one agent, rather 2 or 3 agents. We literally start prescribing from the day one, the first visit when you talk of the patient. So why do we do that? And that is another, as I mentioned, about the window of opportunity. So the definition is, of course, is the window of opportunity in simple words is a time critical period, like whatever that time period is, that if we intervene during that particular time period, we should be able to make or modify some of the natural disease course change. So that is the whole concept. That is the principle of that window of opportunity. And this is the simple, like the trivial hypothesis. What simple is, कि आग तो ज़ाहिर है ये भी आग है. right? Simple. And the other one is the whole jungle fire. So, of course, if we wait for all these, the joints to, of course, flare, if we're talking about or waiting for the 10 or 12 joints to flare, or we're talking about waiting for the extra-articular manifestations to happen, naturally, of course, we have to use much more high doses of steroids or multiple agents. But if we hit a lot earlier, when this only in one joint or two joints, or a lot earlier in the disease course, we will be able to control with the milder the drugs, and of course with the milder dosages, if you like. So this is what we call the trivial hypothesis. So this is the most simplistic way, if I can explain why we need to hit early, but this is not the only reason. So, I mean, this is the randomized control trial, treat earlier. So what they did was, we're talking about the patients with arthralgia. So the rheumatoid factors are negative, right? The patient is coming in with the simple joint pains, MRI proven there is a synovitis in the wrist. And what they did was, they were given one shot of intramuscular steroids, and they were given methotrexate. So this is the randomized control trial, more than 100 patients in one arm, and more than 100 patients in the second arm. And then for 1 year, they were given the treatment. Of course, not surprising. So not surprising, if you look at the red bar, the orange bar, that is the methotrexate arm. Naturally, of course, they did very well. The symptoms were very, very good. They did not have any relapse of the symptoms. But after 1 year, when both, of course, the drugs were stopped. So what happens is, within 6 months, both arms came to the same level that the arthritis flared, right? So what it means is, of course, it's very, very effective that we treat early. You have to maintain at a certain level of all those, whatever drugs we are talking about. And exactly the same was shown with this APIPRA trial. That's also a randomized control trial with the biologics given prior to arthritis. This is important to understand. I'm talking about that the arthralgia state, not the arthritis state. It's the level when the joints have not, that you are not able to clinically examine the patient and comes up with the signs of synovitis. So at the level of arthralgia, the patients were given biologics and prospectively followed. The moment, of course, these drugs are on board, absolutely every single thing is back to normal. Absolutely every single thing, not a single thing showing up. But the moment you stop the drug, gradually, within 6 months, bang, the whole placebo arm and the drug intervention arms comes to the same point. So what does that mean? So it doesn't mean that the methotrexate didn't work. It doesn't mean that the biologics didn't work, right? It means that they were very, very effective, rather a lot more effective at an early stage, but perhaps they're not that effective to reverse the whole cycle of the cytokines. So in other words, when the patient comes to you and me with a simple arthralgia, I'm talking about prior to arthritis stage, perhaps it's already we are talking about a chronic autoimmune process has kicked in, right? It means the whole cycle, the whole cascade of cytokine profile has already kicked in the moment a patient develops arthralgia. And of course, naturally, when the arthritis stage is, that means it's a further next stage of that. I mean, this is one of the very old study, which they looked at was that the first day the rheumatoid arthritis diagnosis was made. So among those patients, a multi-center study, what they looked at among those patients who were diagnosed for the first time with the rheumatoid arthritis, and they found out among those patients who would have some serum or some plasma free somewhere, and they looked back to see at what stage their rheumatoid factor anti-CCP antibody was positive. And what they found out was that a year prior to the diagnosis of rheumatoid arthritis, prior to the development of joint symptoms, more than 50% or thereabouts had already got rheumatoid factor positive or anti-CCP antibody positive, right? If you look at almost 20-30% of the patient, even 5 years prior to the development of arthritis symptoms, they already had those antibodies positive. And around 10% or thereabouts, about a decade earlier, they had these antibody positive. So what does that mean? It means that the whole cascade, the whole cycle, the whole cytokine fooling has already happened prior to the patient's land to us. So it means the whole window of opportunity is a lot prior to their developed symptoms. And that is the most difficult part. And that is what we talk about, the pre-RA. And a lot of studies happening talking about this whole epigenetics, that what can be done. There are a lot of environmental factors which trigger into it, and only in rheumatoid arthritis, the only thing that what is proven is, of course, the smoking, that can happen around those times, which we can, as a lifestyle modification, can bring in. So it means if we look at the healthy controls, healthy patient developing arthralgia without clinical arthritis, and that is the only time if we can intervene to go into what we call drug-free remission, right? And then, of course, we have undifferentiated arthritis, rheumatoid arthritis, and progressive. Earlier on, the whole emphasis was around there, that we need to intervene there so that the rheumatoid arthritis doesn't progress, so that the rheumatoid arthritis doesn't lead to deformities and all this. But here, if we look at, even though we intervene around the time of arthralgia, still we are talking about a patient has got chronic arthritis, chronic symptoms, and we need to control it for a much longer period of time. How long? Literally nobody knows. And that is the only thing why I want to talk about is that we are talking about arthralgia or arthritis in a patient who is seropositive, that these symptoms are unfortunately long-standing, and of course we need to come up with a plan about it. So of course we treat them early because we want to control the symptoms. We want to do, of course, the best for the patients. We want the steroids reduction as soon as possible. So that's why we combine the drugs as soon as possible, so that the steroids or NSAIDs are used just for as an adjuvant treatment, not as the mainstay treatment. And of course, not to forget that we try to prevent irreversible damage, which a lot of studies, dozens of studies have shown that literally the irreversible damage happens around the age of, around the symptom duration of 3 to 6 months. And this is one of our studies as well, that you can see the longer symptom duration, 6 months, a year, 2 years, that the longer the delay, the more long-standing damage happens. And if we treat the patient within 1 year of the symptom onset, we are able to get a better drug-free remission. This was published in the annals. So now the second part is the therapeutic armamentarium. So I'm going to make things, I hope, not complicated, simple. So we have 3 categories we now talk about. One is the conventional synthetic DMARDs, you know, the usual bank, methotrexate, so on, slazodine, and all those, right? So these are what we call conventional synthetic DMARDs. So these are not specific. They do not target the immune systems like a specific targets like the biologics have. So what they do is they dampen the immune system as a whole, not like having the specific target. But when you talk of the biologic DMARDs, for example, of course, they target the specific part. For example, IL-6, anti-TNF agents, for example, or the anti-B therapies, for example. So there are specific targets. So that's why we call them biologics, and they're made from the living cells. The problem is, of course, they are large molecules. They are antibodies, and they're, of course, the molecular weight is too much. So that's why you have to be giving them through parenteral route, either IV or subcut. And naturally, the cost is, of course, more. And then now we have got the availability of the next generation, what we call targeted synthetic DMARDs, right? This is the latest of the latest, if you talk about. They're not specific, but they're selective, right? I have a few slides on those one as well. So they target the selective parts of the immune system to come up with all those blockages of this. They are not made from the living cells. And the good thing is that we call them oral small molecule, OSMs. So that's why they can be given through oral, just like a methotrexate and all this. And they work a lot more quicker, even more than the biologic DMARD. So that's how the treatment over the years has evolved. If you talk of rheumatoid arthritis, 1900s, if you look at the hot water and the minerals and all this, then in 1920s, they were talking about there might be some septic pathology behind it, and so on. I mean, we all have gone through this. But here, late 90s, there is a massive, the whole evolution of the targeted therapies, if you like, right? We have anti-TNF, we have JAK inhibitors, we have the non-TNF blockers. So the JAK inhibitors are the one that I'm talking about, the targeted synthetic DMARDs. I don't need to talk about, but the methotrexate is the first sort of the drug that everybody almost should be on, because of course we have the evidence to back it up, unless there are contraindications. Right? The steroid, of course, we use it only, as I said, the adjuvant treatment. It's only we use it as a bridging therapy because we know that a lot of these biologic agents even, they need at least 3-4 weeks time. Methotrexate needs much more longer period of time. So you have to have some bridging therapy. And we know the steroids work a lot more quicker. The other works within hours, if you like. So that's why we have to have steroids on board initially when the other main drug starts kicking in, and then within weeks we stop those steroids. So this is this intracellular sort of, if you like, right? And this is the extracellular. These are the cytokines. So all the drugs, when we talk of the biologics, for example, so they work outside the cells. So, I'm sorry, So this is, for example, IL-6 or anti-TNF or any of the cytokines, right? They work on the cell membrane, and then the whole cascade of events in the intracellular cycle kicks in, right? So these are the blockages, these are the biologics, all work outside the cells. But these targeted synthetic DMARDs, which is good news for our patients because these are a lot cheaper compared to biologics, right? So they work in the intracellular pathways. So they block literally the whole different cytokines, whatever landing on the cell membrane, and reduce down the transcription, the whole process. I'm trying my best not to complicate things, but the principles I'm saying, as I said, that the biologics are working outside the cells, but these targeted synthetic DMARDs, what we call the JAK inhibitors, for instance, they work in the intracellular pathway. They have a very small molecules. They work a lot more quicker. And as I said, they're a lot more cheaper compared to the biologic DMARD, if you talk about. So we have different generations of JAK inhibitors. One was the initial one, the tofa-JAK, for example, tofacitinib, for example, all these. So these are the pan-JAK inhibitors. So there are 4 receptors of JAK, and they block different cytokines, and they have goods and bads, of course, the whole lot. So the non-selective, just last 2 slides, so I'm not going to take a lot of time. So the non-selective JAK. So these literally block all the receptors, and there are good receptors as well, as I said, and they're the bad receptors. So that's why tofacitinib on one end is very, very effective for rheumatoid arthritis, even spondyloarthritis, and a lot of other. Even we're talking about in SLEs, there are trials going on as well. But these are non-selective. But now, thankfully, we have got not more non-selective or compared to selective as well JAK inhibitors online. For example, we have got now the availability in Pakistan of upadacitinib as well, which is a lot more selective than tofacitinib, which carries lesser side effect profile. So let's move on. So conclusion, simple. We are fortunate enough for the rheumatologist, and as well, I tell my fellows is that it is luxury nowadays to treat our inflammatory arthritis patients because we have got wonderful and cheaper, relatively cheaper drugs to hand. And of course, the only thing is we need to come up with a plan, and we have to tailor depending on the patient's needs. So that's the important thing we need to be talking about. And of course, hit early and hit hard. Thank you.